So these are all the various ways in which patients can present. The cases where this is a child where like your case, the right shoulder is down and the left shoulder is up, or it can be on the contradiction, and you can see the child's gait itself, the limb is lifted up. So when it is very gross like this, automatically the pelvis gets tilted and patient will have an abnormal gait. So don't forget about the gait at all, to ask also.
Okay, sir.
And this is the how you have to elicit the etiology, history examination, imaging, and all that, severity of the curvature, skeletal maturity, and clinical markers to make a decision about surgery. So definition is it's a lateral curvature of the spine greater than 10 degrees as measured by Cobb method of a standing X-ray of the thoracolumbar spine. Okay, so you have to take it. I'm sorry, this is a straight AP view, not a lateral. You can do it from lateral also, and you draw a line from the vertebral body, upper part of the vertebral body of the most tilted spine, and then go to the lateral one. And this is how the whole curvature happens. One side will be the convex side because of the rib getting tilted. This will be the concave side, and the spinous process usually goes to the concave side, and all the other body is rotated to the opposite convex side. And so they ask you about the classification, you can say it will be cervicothoracic, thoracic, thoracolumbar, isolated lumbar, or a combined double primary. So it can be a single area or a double primary. Based on the etiology, most common is the idiopathic, then there are congenital scoliosis, then there are neuromuscular scoliosis. Patients with cerebral palsy also can develop scoliosis. Neurofibromatosis, mesenchymal, traumatic is another reason. They develop injury to the vertebral column in a major accident. Then traumatic scoliosis is also very common. And the measurement of severity, you can see this is how the measurement is done, locating the upper and lower. So again, the same thing. And this is the person, John Robert Cobb, who described this Cobb's angle, which is practiced till today. And deformity, when it was first noticed, and how it was noted, whether it was because the shoulders were becoming unequal, or because the patient started leaning to one side, or whether the patient started walking with an abnormal gait. So that is how you must ask the history, and whether it is progressive, any details of old records, x-rays, any bracing procedure done, or any prior procedures done. This treatment history is very, very important. And commonly, the idiopathic scoliosis does not cause pain, but the other types of scoliosis may cause traction on the nerves and produce neurological or a neuropathic pain, or a muscular pain will be there. And the neurological symptoms, when it is gait problems and loss of balance, when it is especially angular kyphosis. And the cardiopulmonary problem will be if it is occurring very young age, the lung development may not be adequate. So the lung may be immature, and or the compression and the restriction of the lung. It produces what type of lung disease? Obstructive or restrictive?
Restrictive.
Restrictive lung disease. So that is why the patient becomes dyspneic. The lung is not able to expand. So the whole deformity looks like this. And you can see the ribs are getting splayed on one side and they are getting crowded on the other side. Okay, so that is the problem. So when the ribs getting crowded, we will have a restriction in the expansion of the lung, and that will only cause the whole problem. And birth history and development history and travel history, all these things we have asked, and past medical history of any hearing or visual problems because of the infected or other neurological reasons. Sometimes they may have cleft lip and palate or tracheoesophageal fistula, because all the congenital scoliosis can be associated with all these anomalies, or genitourinary disorders and neurological disorders. And examination, you have to examine them from spine with head to toe and neurological examination. These are all the equipment that you may sometimes not used by the orthopedic surgeons or spine surgeon, not by us. And this is how you do. Look for the gait, posture, spinal alignment, skin and sexual maturity. Feel the tenderness or step-offs, paraspinal muscles. Then move the range of motion, flexibility, measure the height and weight, and then look at the posture of the patient from the back and see the spine alignment. So this is how the patients can see nicely how you can see the leg lifted up. This is the lower side, this is the convex side, concave side, and here you can see the gap between the rib cage and the pelvis becomes longer here and narrower here because of the tilt. So you can never have a normal abdominal size. This is how the back looks in various levels. And you can, by drawing an imaginary line, you can easily find out whether the uh, so the flexibility you must try to see how far they can bend on the side of deviation or on the other side, and then you go for Adams forward bending test. This is one of the tests that are done so that they see how far the bending is there, and this instrument they use is called a goniometer. Goniometer. Goniometer is used to find out the elevation of the scapula on the sides and whether it is a sharp elevation or a smooth elevation. That is also are made out. And the lumbar prominence is also another thing which is examined. So if this patient comes for any non-scoliotic surgery, it may be difficult for you to give a spinal. If this lady becomes pregnant and comes for cesarean delivery, then it may be a challenging thing to give a spinal for a cesarean section for this lady. So these are the frontal view, this is the side view, and based on the Cobb's angle, this is a clinical manifestation. Less than 10 degree, no symptoms will be there. More than 25 degree, it will cause increase in pulmonary artery pressure. More than 40 degree, there will be, we require surgical intervention. More than 70 degree, it increases the lung volume because of the restrictive nature. And more than 100, patient starts exerting dyspnea on exertion. And more than 120, patient will have alveolar hyperventilation and chronic respiratory failure. And the treatment can be non-surgical like braces, traction, and application of pins and other things. Surgical, posterior approach, combined posterior and anterior approach or stage approaches. So one question they can ask you is, when will they require a double lumen tube instead of your flexometallic? Any idea?
Anterior approach.
Yeah, combined anterior and posterior approach. When they want to collapse the lung, they may ask you for a WMD also. So this is the other things, pre-anesthetic airway assessment. You have to, especially cervical scoliosis will produce a very great challenge for intubation. So you have to make sure that airway assessment is done properly. And if they are on any traction, that may interfere with securing the airway. And patients with Duchenne muscular dystrophy may have tongue hypertrophy, which may pose a problem in the intubation and other airway management. So the pre-existing assessment, restrictive pulmonary disease pattern will be there. And you must also assess the severity of the curvature by the angle, number of vertebrae involved, location of the curvature, and the degree of loss seen in the thoracic kyphosis. What are the conservative management for mild? This is the younger age group. You can put a abdominal splint or braces like this. So for that also, sometimes they may ask you to give anesthesia because it is going to be stretched and then you apply all the padding and plaster cast. Children may not cooperate, so early stages you may be asked to give anesthesia. And the very young children, the correction is done like that. The gap in the abdomen for them, the rest of the body is kept in the plaster cast. And even adults, they can have this sort of braces for early application of EDF cash to shoulder straps, all these things. And pre-anesthetic assessment, you have to, sometimes they may have reduced vital capacity as the first manifestation. Prolonged periods of hypoxemia result in pulmonary hypertension and hypercapnia and their eventual respiratory failure, just like your COPD. The surgery is performed to slow the disease progression and prevent complications. And the function of the respiratory muscles are limited in these conditions because of the distortion of thoracic cage, and so the lungs, the chest wall becomes less compliant. So it increases the work of breathing. And if it happens in the infantile and the juvenile, associated true lung hypoplasia also can be there because of the thoracic deformity. Whereas in adolescent cases, it decreases the total lung capacity and causes impaired chest wall mechanics that prevent normal inflation of the lungs. And you must do a PFT for flow volume loops to show that there is a airway restriction, and significant displacement of the trachea, main bronchi also can have in severe cases. So you may have to do a preoperative bronchoscopy. And in severe restrictive defects, there may be a decrease in inspiratory capacity, also ineffective ventilatory patterns, and they will not decreased response to carbon dioxide will be there. Neuromuscular dysfunction also may be there. Don't forget to examine for other neuromuscular deficiency. Even though adult idiopathic scoliosis is the most common cause, sometimes they may be associated with all these other neuromuscular deformities. And preoperatively, respiratory function should be assessed by history, focusing on functional impairment and effort tolerance, and also investigations like PFT, and prepare the patient with in-situ spirometry, as you do for all lung patients. Then cardiovascular system, rule out any pulmonary effect causing pulmonary hypertension and right heart problem. So the same thing as we discussed for the last case, ECG and echo has to be done for these cases. And the neurological, make sure a detailed neurological examination is done, and the documentation is very, very important, because these surgeries, when they stretch the spinal cord, there are post-operative neurological deficiencies can result. So unless you have made sure that such deficiencies existed before the surgery and documented, patient can blame both the surgeon and anesthetist for the post-operative neurological deficit. So make sure that you make a detailed neurological. Of course, this is the onus is on the surgeon, not on us. But anyway, it is better that we also know about it before we take up the case. And for pre-medication, avoid narcotics or heavy sedation if the patient has got an impaired respiratory function. You can give them bronchodilators, anti-sialagogues, and also anti-aspiration prophylaxis. Anesthetic technique, intravenous injection is common, and you can use dexamethasone, but in cases of any muscular dystrophy, avoid that. Hyperkalemia in myopathies and denervation can happen. So malignant hyperthermia also is there possibility in this particular condition called King-Denborough central cord diseases, or in cases with adrenal kinase deficiency. And use of non-depolarizing blocking agents for intubation can be better instead of dexamethasone. The anesthetic technique, anterior approaches to spine, you may need a double lumen tube. But posterior approaches, you can use a single lumen tube. The two, a flexometallic tube will be safer. And for maintenance, a stable anesthetic depth is important to enable proper interpretation of this neuromonitoring, somatosensory potential. And if this neuromonitoring is not done, you can do nitrous oxide narcotic inhalation agent technique and a non-depolarizing block bed. This is the common method used for any discectomy or for your laminectomies. But for Patients where you plan to do neuromonitoring, this technique will not be ideal. You have to go for intravenous, total intravenous anesthesia only. And you must have all the routine monitors, including capnography, and temperature and urine output are very, very important. Especially for scoliosis, patients can become hypothermic also because a large area of the body surface is exposed to the ambient temperature. So you must take proper care to maintain the body temperature of the patient. Of course, you may require blood gas measurement now and then. Intravenous fluid should be warmed and all warming devices should be used. And positioning is very, very important to make sure that there is no abnormal hyperabduction or stretching of the upper limb, and the head is kept in neutral position along with the thoracic spine, and there is no pressure on the eyeball or forehead. There is no pressure, undue pressure on the groin to compress the vessels or the axillary area to produce any injury to the brachial plexus. All these things, and the calf, everywhere you must give proper supporting all the bony points. So it is very important. And so this is a picture to show for the benefit of those who have not seen a spine surgery. The patient is induced in the trolley, not in the operating table. And once the anesthetist says, okay, you can go ahead, you can see how many people are supporting the patient. Already he has got all the body warmer and other things fixed in position. So patient is arms are abducted by the side, and patient is to be rotated, and see how they nicely they have positioned it. And even though this looks like a full support, there is a, you can see there will be a gap for the abdomen. Okay, so all the abdomen should be free for the proper. This patient has got such a big belly. Okay, so this is the head end, this is the gluteal region, and there is a gap to allow the tummy to hang around, so that there is diaphragmatic expression is very free. That is a very important. And this position is called the, any idea what is this position called?
Jackknife.
Jackknife position. And you can see where the ECG electrodes are placed. It is not placed on the front of the chest. So they are placed well away from the operative field, but on the back. And this is the infusions that you use for TIVA, for total intravenous dexmed and propofol TIVA. Ideal when neuromonitoring is contemplated. So neuromuscular blocking agents to be avoided. And this is the BIS monitor should be there. If you are planning to give TIVA, don't forget the patient should have BIS monitor to assess the depth of anesthesia, because he is going to be breathing on his own also. So unless you need to maintain the depth of anesthesia, patient may suddenly buck and cough. So this monitoring is needed when TIVA is used for intraoperative maintenance. And this is the erector spinae plane block, even with the ultrasound, so that you can see this is the transverse process. This is the trapezius major, rhomboid, erector spinae. So between the transverse process and the erector spinae muscle, you give the drug, and this is how the whole block is given. And these are all the various frames used for positioning. So what are the care you have to exit? Protect the eye, keep the abdomen free, prevent compression of major vessels at groin, avoid excessive abduction of upper limb, proper padding for all pressure points, cover all exposed parts to prevent hypothermia. And this is how the rods are fixed for this surgery. You can see this is the first side, then bilateral. So this is how you can see how long the incision is there from the upper thorax to the lower limb, I mean lumbar, when they try to do that. It's such an extensive. So Paul Randall Harrington is the person who designed all these screws and the rod. And this is how the whole thing looks after surgery. See, this curvature has been made straight by the use of all these rods and pins. So that much of correction can be done. And they can ask you about the anatomy of blood supply to the spinal cord, because you are talking about ischemia to the spinal cord. Be prepared to answer questions on the anatomical blood supply to the spinal cord. how many vessels on the anterior side, how many vessels on the posterior side, and where are they arising from, and what will be the effect if one portion is getting affected. So all the questions can be asked. So be prepared with that. And spinal cord monitoring, wake-up test. We didn't go into detail about the wake-up test because it is almost becoming obsolete or not conducted proper regularly if after the advent of the somatosensory and evoked potential monitoring. But anyways, some examiners may still ask for that. So who described this test? It was done in 1973 first. You know the person who
Stagnara.
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 Here is Stagnara, the French surgeon. Okay, he was the one
Okay, sir.
who did that, and his anesthetist also was very cooperative, and they used to do that. So you have to counsel the patient, tell them what they are going to feel, then use a very short-acting drugs, and in between you ask the patient to move the toes or the foot to see whether the neurological integrity is not there. But once the SSCP and MEP has come, then the stimulating a peripheral nerve or measuring signals at the cortex is what is called somatosensory evoked potential. Stimulating near the motor cortex and measuring signals at the target muscle is the motor evoked. So you sensory, you go from periphery to the cortex. Motor, you come from cortex to the periphery to see the muscle movement. And they are disrupted by inhalation agents more than 0.5 Mach and also nitrous oxide. So you should totally avoid both nitrous oxide and inhalation agents. And also the neuromuscular blocker affects more the motor evoked potential because the muscles cannot react when you stimulate. So most commonly
Okay,
done with TIVA, and depth of anesthesia is monitored by bispectral index, and you should avoid hypoxia, hypercarbia, hypothermia, hypotension. All the four H should be avoided. Drawbacks of wake-up test: so it requires patient cooperation, risk of patient moving, falling from the table or extubation. It requires skill on the part of the anesthetist to correctly uh, keep the depth and wake up the patient at the time. And it is not a continuous monitoring like SSCP or motor evoke. So you must keep that as a last test because after doing this test and then again deepening the plane, if you stretch the spinal cord, then again neurological problem can happen. So it is not a dynamic test. So it has to be it is done only uh, if the electrophysiological monitoring is not available. If SSCP and DVT, MVT are not available, then you can use this. Or if those monitorings fail or they produce equivocal results. In that situation only, Stagnara test is now done. So this is how the electrodes are placed for the evoked potentials in the scalp, and then the for motor evoke, you stimulate the motor cortex and see the response in the motor muscle. For the sensory evoke potential, this is where you put the electrodes, the posterior tibial nerve and sural, anterior tibial, all these sensory nerves, and then try to stimulate. And this is how the picture of the display will be seen. So based on the latency and amplitude as we described, they can be seen as a response to stimulation. Okay. And blood conservation is the another thing which we talk about. The blood loss is usually 10 to 30 ml per kg. So you have to keep blood ready in case you have not done any of the pre-operative preparations. So for reducing the blood loss, intra-abdominal pressure should be minimum. You can use hypotensive anesthesia, but surgeon, if he doesn't want, you cannot do that. But always maintain MAP between 60 and 65, and antifibrinolytic agents. This one I forgot that what we use nowadays routinely, tranexamic acid, that can be given both
yes, sir.
at the beginning as well as at the end of the procedure. And you can use autologous blood transfusion, or you can use acute normovolemic hemodilution, or you can use intraoperative self salvage, or you can infiltrate the operative site with the dilute adrenaline containing solutions like adrenaline saline or permission local anesthesia. Post-operative care, this patient should be in ICU, 24-hour monitoring, and make them breathe with intensive spirometry. Other neurological injuries or ileus, pneumothorax, dural tear, urinary complication, or sometimes SAID secretion also is very common. For post-op analgesia, multimodal approach, the combination of paracetamol, NSAIDs, opioids, the intravenous opioid infusion, PSA, PCA, patient-controlled analgesia. Intrathecal opioid also can be given, epidural also can be given, intrapleural infusions, low-dose intravenous ketamine, especially for patients who have opioid addiction. This is the method that is recommended for patients with opioid addiction after spine surgery. Postoperative visual loss is another question that can be asked. It's very uncommon, but sometimes it can happen. And the reasons are it can be ischemic optic neuropathy, central retinal artery occlusion, cortical blindness, or posterior reversible encephalopathy syndrome. And pathophysiology of all these things they can ask you is increased venous pressure in the globe, interstitial edema, increase in intraocular pressure, compression of vessels supplying optic nerve, or hypoxic optic nerve injury. And the risk factors are low post-operative hematocrit, presence of vascular diseases, long duration. Of course, if it is a cardiopulmonary bypass, it is common in that also, and use of blood and other components. So retinal ischemia can be of central retinal or branch of the retina can be affected, and ocular trauma also can produce. So this is the one case which I did before I stopped my practice 2 years ago, where I had to give for a PCNL, that is percutaneous breaking of the stone. The patient was like this, induced, and then we did until GA. Okay. Right.
Thank you, sir. Any doubts from the students?
Sir, good evening, sir.
Mhm.
Sir, if the patient is means kyphotic angle is quite large, means how will we intubate the patient if he is not able to lie supine, sir?
Yeah, you must, if the neck movement is normal, your malambatic grading, neck movement are all normal, you can do intubation in the lateral.
Okay, sir. And sir, in kyphotic, means kyphoscoliotic patients giving spinal, sir, means distribution of the spinal drug that will be uneven, na? Means, so how will we able to reach the level what we want to
Cannot
block?
definitely be sure about the level that you achieve. First of all, the identifying the space itself is very challenging. And
Yes.
as I said, that is why I showed one of the pictures where how the spinous process will be turned. It will be always turning towards the concave side.
Okay.
Okay?
Yes.
So you
Yes.
go from the concave side, and in between that side, if you go, you will have a larger gap between the lamina. So many times people what they do is they try from the convex side. If they try from the convex side, it is very difficult to approach because the spine is turned towards the concave side. So you will be going and hitting the spine or the lamina. So if you try from the concave side, majority of the time you will succeed. And if you succeed and if the lateral curvature is involving the lumbar and thoracic, as soon as you put the patient down, you try to give as much as possible some head down tilt so that it will travel up to the maximum thoracic level to achieve T3, T4 or T5 level.
Thank you, sir.
Can we close?
Thank you.
Then?
Thank you, sir.
Thank
Yes, sir. Can we sign off?